I'll begin now with the presentation. And as of now, I'm sitting in my clinic in car, just finished with the day's work, not changed out of my costume still. But I thought this is a good time to sit and discuss a topic in a clinical setting. When we are looking at a good result in implant dentistry in the aesthetic zone, there is somebody who's still not muted. Please check, guys, your connections and mute yourself. Okay, now it's better. So we are looking at a perfect emergence, and we are looking at a very good harmony between pink and the white. And we want to see to it that the interdental papilla and the tissue health and everything remains great. So when we are looking at these type of cases to finish, we want to see to it that we set up the case nicely to finish it well with the lab. Give me a moment. I'm again stuck with my PowerPoint. Give me a second, please. Okay, everybody can see this slide of the teeth in the cross section, a view from the side.
Yes, sir.
Okay, so we all want these successful results, but the amount of hard work that it takes to get these beautiful results is what I want to uh, explore today. I want to show you a pathway with which you can achieve these excellent results by following some cardinal rules in the aesthetic implant dentistry. This is one of my first cases which I did of first big case which I did of anterior central incisor around 10 years ago. This was, and that's how we finished up at that time. And when we saw the end result, we were very happy with the way the upper left central incisor now matches. Although there is a slight amount of recession of around say a few microns as compared to the pre-op, we managed the overall pink and white aesthetics and the ceramic work pretty well for the lab support that we had at that time. I've followed this year case now for subsequently 10 years. And on your screen right now, you see a 10-year follow-up of that patient. This was done in 2009. So this is in fact the 11th year. And over the years, we have seen that the result with the upper left implant has remained stable. There is no chipping of ceramic, which is anyway not expected in the aesthetic zone. And the tissues are holding up well. So what does it take for us to get the results looking like this, and how do we maintain this over a long period of time is our goal today. And I'll get straight to the point because I have only around say 50 minutes with you, and I want to give you maximum information that I can so you can utilize it in your practice to help yourself serve your patients better. These are the five P's that we have in the five rules which we follow. Yeah. So the first is the planning, and we will talk about how to plan for a case well. The second is the placement protocols. Then we will look at adjunctive procedures that we always need to employ in the aesthetic zone. And we will look at how to make a provisional restoration and use that as a scaffold for designing our prosthetics in the end. Okay. And I'll show you a variety of 4 or 5 cases in the end, with which I'll make all these points very clear. So first step is your P1, and that's planning. And for any case in the aesthetic zone, there are 8 clinical parameters which I study. Sometimes I study them with the patient on the chair. Sometimes I take good pictures, good x rays and scans, and then do the assessment of these parameters in the absence of the patient. So my first and the foremost, the most crucial parameter is lip line. If a patient has a high lip line, a gummy smile, that case is going to be very, very tough to deal with. So you can be rest assured that you'll be pushed to your limits of your clinical skills to achieve a great result for a single central incisor or two teeth missing for a smile that is like this. So the moment the patient has a high lip line or a smile line and a gummy smile, start lowering the expectations right from the beginning and see that you follow a very cautious approach in your treatment and don't try heroics, because failures in implant dentistry are sometimes not easy to correct even after the patient is willing to pay for them again. So biology is sometimes unforgiving. The second parameter is see the tooth position, where it is in relation to the adjacent teeth. Is it more apical or is it more coronal? The more apical the tooth in question as compared to the adjacent tooth, the greater you will have to work hard, because now you already starting with recession. So you have to not only place the implant in a way that the recession is maintained there, but eventually in the treatment you'll have to start to deploy techniques which will allow you to get the tissue back to the coronal side, which will then match with the adjacent central incisor. So this increases the risk for these cases. The third is gingival biotype. The thinner the tissues, the more challenging it's going to be. Your incisions will lead to more recession. Your suturing techniques will matter. The flap cannot be as wide as you want it to be. Otherwise, it can lead to a problem. Okay, so the fourth factor is the scallop of the gingival margin. How scalloped is your margin? How triangular are your teeth? The greater the scallop of the gingival margin, the thinner the tissue, the more triangular the teeth, the more the chances of having a less than optimum output in the end as far as excellence is concerned in this zone. We also need to take a probe and measure the bone on the adjacent teeth. And if you are starting with a vertical defect, you are going to be in trouble with these aesthetic zone cases. So ideally, when you probe the interdental papilla, your probe should reach at the most a mark of 5 mm. Anything greater than that is going to be considered as vertical bone loss to start with, and then the papilla will go and settle down at a more apical level, and to get it back during the treatment surgically is going to be practically impossible for you. So you see the bone levels, especially in the interproximal area for the interdental papilla. Sixth, you see the infection at the implant site. There should be no periapical infection as far as possible. A small lesion, which is less than 5 millimeter in diameter, which does not interfere with primary stability of the implant, is okay to have. You can curate that site and still place the implant. But if it's a very large lesion, which leads to no palatal or buccal bone in which you can place an implant nicely in the socket, are going to be contraindications for your uh, immediate implant placements, and they are risk factors. Okay. The next is the available restorative space, which it should be sufficient to make cement retained or a screw retained restoration. The minimum space you need is around 5 mm to 6 mm for a screw retained, and around 8 to 9 millimeters for a cement retained restoration. For multiple teeth, you have to see how many teeth are missing. The more the number of teeth missing, the greater the chances that you will end up with a less than optimum aesthetic outcome. And that's why you will have to be sure that you communicate that with the patient. Sometimes, when multiple missing teeth are there, you may need to use some form of pink ceramics to get your case done well in the end from a pink and white balance point of view. Okay, so pay attention to these 8 critical parameters, and every case in the aesthetic zone that you do in your planning stage, you should have the answer to these 8 questions. Where is the lip line? How is the tooth position? How is the gingival biotype? And etc. etc. Okay, so I hope this part is very clear. Am I audible to everyone? Everything good, Dr. Aarti?
Yes, sir. All
Okay.
good.
After you've done your critical evaluation, you then need to start doing a radiographic evaluation for planning. The first thing you evaluate is how is the root trajectory in the aesthetic zone. Sometimes the root is placed in the mid section of the socket. So you remove the tooth and you go in the same direction of the apex to place the implant. Sometimes the socket may be in a different position, but the tooth is in a different position, and that leads to uh, osteotomy which requires to be created in a different direction from where the tooth is. So you have to study the classification of the root in the socket to assess whether this case is a good case for extraction and immediate placement, or whether it's a case in which you should do an early placement where you will extract and wait for some time and then come back with an implant placement at around 8 to 10 weeks. So the root trajectory is something which you'll see on a CT scan. You can't see this on an IUPA. Okay. The second factor that you will see in the scan is how is your socket morphology. Is there enough bone left after the extraction of the tooth for you to achieve primary stability on the palatal side of the socket? Is what you will measure. And if you don't have that bone, then after extraction of the tooth, it's better to wait for 8 weeks and then come back with an implant placement. The third factor that you will see is how is the integrity of your buccal plate. So if your buccal plate is not present, it's absent, then it's a type 2 or a type 3 type of a socket morphology. In that case, you may sometimes not be able to do an immediate placement. Of course, as time goes by, we have now learned of techniques in which even with no buccal bone, we can do extraction, place the implant and do a grafting with large number of techniques. But those skill levels required for those techniques are very high, and the experience that you need is a lot. So if it's your first case in which you don't have any buccal bone and you're going to extract and do an implant placement, I would advise you to be cautious before you take up that case. The anterior maxilla is full of very notorious dimensions of buccal plate, and that's why ideally you should be able to see a buccal plate on a scan to be able to attempt an implant placement in that zone. So we first studied the clinical parameters in the planning, and now we studied the radiographic parameters of root trajectory, socket morphology, and buccal plate integrity. The second principle, the rule that you have to follow in implant dentistry is that the implant should be in perfect three-dimensional position, buccolingually, mesodistally, and occlusal cervically. So you see this green zone in the first figure over here. That's where your implant should come, keeping a space of 1.5 millimeters from the adjacent teeth. If your implant goes close to the adjacent teeth, you will not have a papilla there when you finish. So your implant placement has to be perfect in the mesodistal position over here. When you look at the next picture over here, it tells you about the depth of the implant. The implant has to be at a depth such that the platform of the implant is 2 millimeters apical to the CEJ of the adjacent teeth, or 3 millimeters apical to the free gingival margin of the adjacent tooth. So when you are planning your case on your scans, you have to see that you are able to place the implant at this depth and get enough height for you to be able to place an implant in the correct position. The last parameter to follow is to see to it that your buccolingual position of the implant is such that when you join lines on the adjacent teeth in this manner on the figure on your extreme right hand side on the screen, the implant platform should be lingual to that dot. The implant should not emerge from the labial side of the socket or of the delayed side as far as possible, because that will lead to thinning of the buccal cortical plate and eventual dehiscence and recession mucosal. So that will lead to a less than optimum aesthetic output in the end. Okay. So when you look at this scan over here, I've purposely put this scan. It is a very thin buccal plate, and where do you want the implant to be placed in this socket is what you have to think. That's where I want the implant to be, such that the long axis of the implant emerges from the cingulum lingual fossa junction of the final tooth. It should not be from the incisal edge or labial side as far as possible. But sometimes what will happen is that uh, in an attempt to place the implant in this manner so that the long axis comes from the cingulum, you end up creating a fenestration on the buccal cortical plate, and thereby you will need to then open that site and place a graft. Instead of doing this in such sockets, I sometimes prefer that my screw access hole comes from the incisal edge. Now you see, because I've placed the implant from the incisal edge, I've got a thick space between the buccal cortical plate and the implant where blood clot will form and new bone will form. So I will be able to get a thicker plate in the end after the healing is accomplished. So this is where we sometimes differ from what literature says that everything should be screw retained. I'm okay to have something cement retained as long as my implant is in native bone and I don't have to graft. That's the philosophy I follow most of the times. So look at this particular patient over here. It's a beautiful picture of a very dirty smile in which there are a lot of faulty restorations. The underlying teeth of the patients are failing. I've taken a scan. The patient needs a smile design. So I'm going to plan the smile design aspect for this patient. But along with that, now I need to do some gingival procedures. I need to place 3 implants for this patient in these regions that you see here. And along with that, manage the pontic sites such that I'm not going to have too much of bone loss over there, and I don't have to rely on pink prosthetics for my final result. So here I'm in the P1 zone and planning what needs to be done. And when I remove the faulty prosthesis, I realize that I have to extract some teeth totally, and some teeth I will be able to save partially and then place an implant. And look at the socket morphology over here. When I remove the tooth, there is hardly any width available on the socket for me to place the implant palatally. I'm having very, very tight space. My margin of error in this case is so little that if I make a mistake of 5 degrees, I will perforate the buccal cortical plate or will come out from the parietal cortical plate. So the skill required for you to be able to do this is very high, and you need to acknowledge that so that you don't make heroic attempts in trying to fight biology and making errors which otherwise nature would not allow you to get away with. You see, so I start looking at virtually where I want implants to be in this sockets. And my 3 sockets, I have planned that my implants to be narrow diameter, placed in this way. That means my root is going in a different direction and my socket is in a different direction. I have to make the account for that during drilling protocol. Otherwise, I will create buccal fenestration, which will then require me to use the bone grafting materials to a very large extent. That won't only increase my cost, it will also increase my success rates. So I take a scan for this patient, and for such patients where I have very little margin of error, I sometimes prefer to plan a pilot drill guide or a fully guided stent with which I can place the implant in the correct positions. So these stents are now very affordable. I'm very, very heavy on guided surgeries in the last 1 year. And I realize that it allows me the option of reducing the number of mistakes that I may make because of human error in implant placements. So it's a part of technology which I really like to explore in my daily implant practice. And these stents are all tooth supported, very easy to manufacture, and then I can go ahead and extract the teeth and place the 3 implants in the areas that I thought perfectly, and then go ahead with my prosthetic phase, which we'll discuss later. So here is the panoramic view of these 3 implants placed with guided surgery after doing some form of socket management for these extraction sites. So I've done the P1 planning well, and I've done the P2 placement well. Okay. The third P is the P for PET, that's partial extraction therapy. But I also added adjunctive procedures because if the tooth patient comes to you with a tooth in which PET cannot be done, or if the tooth is already extracted, then in that particular case, you will have to know other methods like GBR also. Dr. Aarti, everything okay?
Yes, sir. All fine.
Okay, okay. So partial extraction therapy has 3 treatment modalities. One is root submergence. The second is known as a pontic shield, in which the tooth has a periapical lesion. So you do a socket shield, you are not sure you'll get primary stability. And the third option is a socket shield in which you place the implant in the socket after the partial extraction is done, where the buccal part of the tooth is left intact on the labial cortical plate, thereby cheating the body into thinking that the tooth is still present. So that's how we are dealing with these adjunctive procedures like partial extraction therapy to allow us to get a better result around an implant site. So this is a canine which I have extracted, but not completely. I left the buccal portion of the tooth intact, and now I've got enough palatal bone as per my scan to place my implant in the correct palatal position, not keeping any space between the palatal, between the implant. I'm sorry, not keeping any contact between the implant and the shield. I will see to it that there is space between them. In the end, when I finish up placing the implant in the canine region, now you can see that the implant is prosthetically placed in the right position, not touching the shield. And the buccal shield in the canine region, where the bone is usually very, very thin, will make the body think that the tooth is still present. The sharpish fibers are still connected to that labial sliver of tooth, thereby not allowing the labial bone to be lost. And when I see the healing of the site, I see that I've got beautiful tissue contours, just extremely robust tissue contours in the canine region. And in the premolar, you see it was a delayed side. I couldn't do any PET over there. And you see that there is a slight dip, and the color of that gingiva has changed a little bit. It's become more gray, and that's what happens over a period of time. So what we are looking at is in these type of cases is looking at the P3 or the PET to help us enhance the aesthetic result for our cases whenever possible. And that's the end result of that cuspid. Of course, sometimes PET is not possible, and I need to resort to what is known as guided bone regeneration. So I would say today, if I would have a tooth present and firm, I would consider PET. But if I have a tooth absent, then I have to look at procedure in which I'll regenerate bone in this manner. So when we place implants, as you can see here on the left hand side in the lateral incisor region, sometimes in the anterior maxilla, the bone is so thin after the osteotomy that if we leave it the same way, it's going to resorb over a period of time, thereby causing mucosal recession and causing an aesthetic failure. So what is the better thing to do here is to add some bone and a membrane to do what we call as a contour augmentation to maintain the contour of this buccal bone over a long period of time. And many students or participants or clinicians I discuss with, there's a lot of confusion as to what type of bone to use. The type of bone to use depends on what you want to do with that bone. So, if you want to regenerate the labial cortical plate and then maintain the contour also, then you need autogenous bone and then artificial bone on top or xenograft on top. But if you are only doing contour augmentation, as in this case, then you don't need autogenous bone. You can directly add a xenograft, a slow resorbing bone substitute to maintain the contour in that zone. Okay, so whenever you're trying to regenerate the labial cortical plate, always use the autogenous bone first in contact with the implant. This autogenous bone I harvest from intraoperative sites like the anterior is the spine of the tuberosity or the ramus of the symphysis. It's very easy to do, and you crush the bone, make it particulate, and layer it on the implant. So just like how you layer composite resins, you also layer these grafting materials with the autogenous bone going in contact with the implant first. Okay. Could also use a zero graft. So based on your requirements, your living bone substitute will take your and replaced by patient's own bone. So it maintains contour well. That itself can be a disadvantage sometimes when you want a good quick turnaround of bone. Okay. You could also take bone from another human cadaver, and that's known as an allograft. Okay. The last thing you can use isn't sorry. Is everybody okay? Dr. Arti, everything fine?
Yes, sir. All fine.
Okay.
Dr.
Yeah.
Samira, please mute yourself.
Okay. So you, what I'm talking about here is the aesthetic zone. I generally don't end up using alloplast like a a novabund putty or a beta tricalcium phosphate in the aesthetic zone these days. So I'm not mentioning them here. These are my three choices that I have in these two slides. Along with this, you also need to use a resorbable collagen membrane. You could use non-resorbable ones also if you're doing vertical grafting, but I'm not talking about that aspect here. I'm talking about guided bone regeneration around an anterior implant. For that, most of the cases we use a resorbable membrane, preferably with a slow resorbing rate so that it remains in place for around 8 to 10 weeks or more so that it can allow new bone to form within it in a very protected environment. So somewhere in your training, you'll have to learn how to master the use of these products because at some point in your implant career in the aesthetic zone, you will need to use these materials to get a good result. Okay, so here is a site where in the premolar, after placing the implant, the buccal bone was very thin. So we are doing some bovine bone in this region on which we have then put a membrane and adapted it nicely. And you don't need to tack the membranes all the time. You can stabilize them with holding sutures and then achieve a good primary closure. So that will allow you to do a guided bone regeneration around your implant placement, which is what we are talking right now at P3. Okay. So in P3, there are three things you can do. One is partial extraction therapy, the second is guided bone regeneration, and the third is a connective tissue graft or any other soft tissue procedure. So sometimes we have the implant in the perfect position. We have the bone around the implant, but we are lacking a little bit on the soft tissue. So if we harvest a little bit of the connective tissue graft from the patient's palatal tissue and put it in the right place at the right time, it gives us more volume of the tissue. It allows us to work with a better biotype, and that gives us a good result in the end. So these type of procedures are always required. So in our presentation so far, we have learned the three cardinal rules. One is always plan well based on the eight parameters and the radiographic parameters. The second is always place your implant in the prosthetically correct position in the bone. And the third is make use of one of these three aspects, PET, GBR, or CT grafts, to allow your site to be optimized to get a good end result. Okay. The fourth aspect is a restorative aspect, that is maintaining good designs on provisional restorations. And this, after you've set up the case well, this plays a very important role in achieving a good finish. So these provisional restorations should help you to get a contour around the implant, as you can see here on the extreme right of your screen, where you will have good, healthy, robust tissue shape to the emergence profile that is required for that aesthetic zone. In this provisional restoration, the shape that you have for the provisional can be concave, as you can see on your left hand side, or it can be convex, as you can see on the right hand side. This shape which I'm talking about is not the shape which is visible in the mouth when the patient smiles. It's the shape which is present subgingivally. Okay, so this shape has to be dependent on these four categories. It's your socket morphology, your implant depth and trajectory. The more labially the implant is placed, the more concave the provisional has to be. The more palatally the implant is placed, the more convex the provisional will be. The thinner the biotype, the more concave the provisional. The thicker the biotype, the more convex it can be. It also depends on the placement protocol and what you want to do with the tissues. These subgingival areas of the provisionals provide you with great armamentarium to move the gingival margin apically or coronally should you desire to do that. So if you look at the colors here, the green color is 1 millimeter subgingival shape of the contour of the provisional. That's known as the critical contour. And the portion that is in red color, that is beyond the critical contour up to the implant platform, it's known as a subcritical contour. The moment you change the critical contour, you can take the gingival margin more apical or more coronal. So if you're a patient in whom you have started with a little more recession and you want to get the margin down, then you make your critical contour more subdued, more concave. So your gingival margin will start to come more coronally. If you feel you have too much tissue and you want to now push the tissue more apically, then you contour your critical contour more convex, and that will lead to your gingival margin going more apically. Sometimes surgically, small errors here and there can be easily accommodated by designing a good provisional restoration. I'm not saying that you should make errors, but we are human beings after all, and all patients don't come with ideal parameters all the time. So to overcome the problems that we face in the surgical arena, the restorative platform here can allow us to design things in a better way by understanding these contours. And the article quoted over here is what you should read to understand this further. Okay. The last cardinal rule is always design your abutments as far as possible in the aesthetic zone in a customized manner. The material doesn't matter. You can use bio HPP, you can use zirconia, you can use titanium if you have thick biotype and the gray shadow of the titanium is not showing through. It's fine. But as far as possible, I prefer to customize all my abutments in the aesthetic zone when I'm dealing with any case from the upper cuspid on the left to right side. Okay, so these customization can be done for color, for angulation correction. If your implant is not angulated correctly, a customized abutment will help you achieve that. It's customized sometimes for length because your height of the abutment is too less of the stock abutment. So you can customize and get a better length in your final abutment. And we also customize for margin placement. Look at the center picture over here. The margin has the rise and fall that the CEJ of the tooth has. That rise and fall is designed in such a way that my restorative margin will never go deeper than a zero point 0.5 millimeter into the sulcus. And so cement cleaning will always become easy. So when I'm making cement retained restorations in the aesthetic zone, I always prefer to customize as far as possible. And nowadays, the cost of these customization is not as high as it used to be 5 years, 10 years down the line. It's more easy, more achievable, and sometimes in some cases, angled customized abutment would be actually more economical than an angled abutment for some systems. All good, Dr. Adi? Are you with me, Dr. Arti? Everything okay?
Yes, sir.
Okay.
I think
So,
one person needs to mute himself. Or
okay.
F1S.
So let me see. If I try to do something, I will get my PowerPoint will get stuck. So please mute somebody who is not muted. Okay. Let me show you a case now to discuss how these five P's work together for this challenging case. There's a young guy, 23 or 24 years old, and he had this faulty crown with the margin visible. He came to me to change it. So I said, okay, we'll remove this, do a crown lengthening and change your crown. But when I took an X-ray, I realized that he has an implant inside these lateral incisors, and the implant is placed very shallow. It's not placed deep enough. The implant should be 2 millimeters below the CEJ of the adjacent teeth. In this case, it's 2 millimeters coronal to the CEJ of the adjacent teeth. So I can't get the height in the restorative area that I need. So when I look at the X-ray, I realize this is the problem. Now the CEJ is marked in green and the implant platform is marked in red. That implant platform should have been where this yellow line is. So the previous dentist made a proper implant placement buccolingually and mesiodistally, but got confused with the depth of placement, which is a very, very common error. This is a very common error in aesthetic zone. So the patient is aesthetically very demanding, and here, because of the shallow placement, I don't have any running room. Running room is a room that I want from the implant platform till the restoration emerges from the gingival tissue to shape the subgingival area, where I will make my critical and subcritical contour better. That room I don't have. So my emergence is very square, and I cannot now help this patient with the existing implant in the existing position. So I decided that the only way in which my planning allows me is to explant this implant. Okay. So again, the patient is very young, aesthetic demands are very high, implant is integrated, but in the wrong position. Okay, so now I don't only have to remove this implant, but if I do this case, I have to have the responsibility that all my five P's go well so that I end up much better than what I started. It's a big demand, and this is something which you need to understand. So I explanted with a trephine very carefully both the implants. My goal was not to create a buccal dehiscence or a fenestration, which I successfully avoided. Okay, so I removed both the implants very carefully under a lot of magnification, very slowly with stable hands, placed a new implant in the correct position, buccolingually, mesodistally, and incisor-cervically, okay, and left enough space between the implant and the buccal wall to graft that area along with contour augmentation to let this patient have a good, robust buccal cortical plate. Okay, so that's the membrane, and that's your here I've used allograft in the socket, which is the uh, bone from a human cadaver, something like Rocky Mountain. And on the buccal side, you can then use a mixture of Rocky Mountain along with the xenograft to maintain contour. Because I raised the flap so much, I then pulled the entire mucogingival tissue and achieved primary closure and achieved good healing. In my healing period, I made a Maryland provisional, and after 4 months, the patient looks like this. Implant is indicated, and now I open the site and I do my adjunct procedure. My adjunct procedure is P3, a connective tissue graft, to make the tissue around this area more robust and also allow the attached gingiva around this site to be more thicker in section so that it gives me a good aesthetic end result. Okay. After I've allowed around 3 or 4 weeks of healing, I'm now making my provisional restoration. And now I have another problem is that with my provisional restoration, my gingival margin is still not right. The margin on the lateral incisor needs to go more apically. I have too much tissue over here because of what I've done, which is good thing in implant industry. It's not a problem. So what I do is I remove the provisionals and I start to modify the critical and the subcritical contour. I start to add some composite on the subgingival area here to make my provision more convex. When I make my critical contour convex, the gingival margin will move apically. Okay, so that's how I started. On the left hand side of the screen, you can see a concave contour. I made it more convex for both the lateral incisors and placed that so that now my margin has gone more apically and it stays still coronal to the central canine line, which is where the lateral incisor gingival margin should be. So with this one case, I hope I've been able to make you understand how the shape of the provisional can actually uh, govern the gingival margin placement for you. So that was my P4. And then in the end, I'm going to take some impressions and customize the abutments as we discussed earlier. That's how we started. And after around 8.5 to 9 months of treatment, of course, there was a big healing period in between when we were not treating the patient. I've now ended up with the lateral incisors perfectly placed where they should be from the gingival margin standpoint and not touching the adjacent teeth at all. Whatever was done in the lateral incisor side. And now when the patient smiles at dirty, squarish emulsions and the margins that were there initially are all gone. And this is what understanding the subject of implant industry will allow you to achieve. When you identify the problem in the planning stage, you can then overcome the mistake that is done in the initial stages by the earlier dentist and then overcome that in this manner. Okay, so I hope this was clear for you. That's my post-op X-ray now, and you see this X-ray is now with the implant platform 2 millimeters apical to the CEJ of the adjacent teeth, along with all other parameters being correct. Okay, so what I'm going to do now is try to show you some cases and see how we achieve this excellent tissue health. Just sticking to the 5 P's. Okay, so that's a single implant. Patient had trauma in the upper right central incisor has broken. So you will see down on the slide, I'm at P1. So I will take a scan. When I look at the X-ray, I realize that there's a coronal radicular fracture horizontally. The coronal part has fractured. There is no infection here. There's slight edema because of the trauma, which happened around 24 hours earlier, and now the patient has reported to us. So we are going to remove this coronal part, and because we have the tooth present, we are not going to extract the whole tooth. Okay, we'll do what is known as a partial extraction therapy, keep the socket shield in place, and I will also graft this gap. In this particular case, I did not make a provisional immediately on the implant because I was not very happy with the primary stability. My insertion torque was less than 60 at the RFA value. So I didn't want to take a chance. I decided that I'll graft and let this heal in a more safer environment and make a Maryland bridge on top. Okay. So I did that. And that's my grafting along with the PET. And now I have made a Maryland bridge, send the patient back home, see him at 8, 10 days. And after 6 months, it all looks very nice. You can see the contour on the upper right sentence as a perfectly matching the contour on the upper left. Okay, because of the PET and the grafting that has been done. The case is now set to be taken into its restorative phase where I'll make a provisional. So I'll design the provisional with proper contours, and you can see the X-ray over here. The contour subgingivally will be concave so that the provisional doesn't touch the shield. And that's how my tissue looks 2 weeks after the provisionals have healed inside. Okay. And then I will go ahead and take a digital impression of this area and then plan a zirconia abutment in a customized way. So when I'm doing that, I will look at the information that I can provide to the lab so that he can design my margins very nicely for the custom abutment. And then I go ahead and screw this customized abutment onto the implant, torque it to 30 Newton centimeters, and then cement my Emax crown on top of that. And that's the final result. It's an immediate post-op, and we've followed this case for around 2 years now, and it's holding up well. Okay, so following the pathway of the 5 P's, the planning, the placement, the PET, along with the grafting in this case, the provisional, and then the customized abutment and final restoration, we are able to stick to the excellence that we require in this zone. Okay, and that also gives you an idea of how healthy the tissues are. That's the postoperative X-ray showing you the outline of the shield along with the implant placed in perfect position buccolingually, mesodistally, as well as incisor-cervically, and then the customized abutment having the concave contour that we wanted in the final restoration. Okay. Sometimes I have patients like this where the patient is not very demanding, and but I want to achieve a good result in the end, because sometimes when the patient is not demanding and the result is bad, they become demanding. So I didn't want that problem. But this is a 70-year-old patient, very bad teeth anteriorly. I'm not going to extract all these teeth. In my planning, I will see the socket morphology, and that's conducive to a good implant placement after immediate extraction. But instead of extracting the tooth completely, I will do a partial extraction. Now I don't need 3 implants here, I need only 2 implants. But all these teeth have periapical lesions. So what I'm going to do is in the center tooth over here, I will use that as a pontic, but I'll prepare the shield, remove the apex of that tooth, remove all the infection, and use that site as a pontic shield to maintain this robust convex contour that you see. Okay, so I do my decoronation, shield preparations of all 3 teeth, place implants in the 2 adjacent teeth, and keep the center as a pontic shield. Okay, and then go ahead with a final abutment on the day of implant placement, on which I'll make a cement retained provisional. Sometimes these provisionals are so tight by themselves that I don't even need to use a cement. So that excess cement problem in the surgical phase is not going to cause any loss of integration, which is a concern for me. Okay, so I allow little breathing space for the tissue, and then at 48 hours, the patient looks like this. Look at the healing of the site, and at around 4 months now, or rather 3 months, I've got beautiful contours maintained on this. And remember, in this case, all I've done is PET. There is no grafting, there is no biomaterial used. It's just perfect implant placement along with PET to allow us to get this type of a result. Now, because I use a final abutment, I'm not going to extract that abutment on the day of the impression. I'm sorry, I'm not going to unscrew that abutment at all. I'm going to use that abutment to, I'm sorry, take a crown and bridge impression and then go ahead with the fabrication of a Emax bridge. So I send the data to the lab, and you see my margins uh, palatally are so supergingival that cleaning of the cement is not going to be an issue at all for me. Okay, and the lab does this beautiful work for me, which I can then go and bond onto these bio-HPP abutments, which are here prefabricated, onto which I'm using a visual line bond to bond my final prosthesis. So that's how the end result is. And you can see, when you see from a very close standpoint, you'll realize that I have not lost any tissue at all. The entire pink is present the way it was on the day of surgery. There is almost negligible or unaccountable gingival recession, and it's not only the shape of the tissue which is maintained, it's also the quality. Look at the quality of the tissue which you can get by using adjunct procedures like PET in your anterior implant industry. Of course, the PET process is technique sensitive. You need practice, you need training, but in this day and age, training and education is not a problem at all for us to achieve. Okay, so that's the picture of the patient at 6 month follow-up, where I've tried to show the stippling in the tissue, and the pontic is so beautifully designed that it appears as if it's a tooth, as if it's a tooth emerging from the underlying socket, and that little shield which is present in this pontic allows that gingiva or the bone to think that the tooth is still present, and that's why you don't end up uh, with a dull, flat contour in these areas, which is a common problem with crown and bridge work. And that's the patient scan at after the work has been completed. Okay. Now let me show you a case in which we couldn't do GBR. So why we couldn't do GBR? Because this case was done almost 8, 9 years back. At that time, there was no concept of partial extraction therapy, uh, and so my goal here was, in spite of having faulty teeth in these 4 incisors, when I removed these teeth, I realized that the central incisors inside cannot be saved. So I extracted them. But after extraction, because of the socket morphology not being conducive to an immediate placement, I decided that we will do a T2 protocol where we'll come at 8 weeks and then place the implant. So I opened the site with a wide flap base to allow me to place the implant at 8 weeks in the perfect prosthetic position and do a guided bone regeneration in the classic manner so that I can have a good end result here. So there was a remnant of a root remaining over there, which I removed. And in my quest to remove the root completely, we realized that now we have a dehiscence on the buccal bone. So now remember, I have to generate or rather regenerate the label cortical plate. So here, my choice of grafting material will involve an autogenous bone for sure. Okay. So I placed these two implants beautifully in the position that they are supposed to. At that time, I was not so heavy on guided surgery. This was all done freehand. And then I harvested some chips of autogenous bone from the ramus. I crushed them into these large particle size, and I put this autogenous bone in contact with the implant, on top of which I used the only available bone in our country at that time, which was tricalcium phosphate. We didn't have materials like bovine bone bios or porcine bone like Mineros XP, which we have today available at that time. So I put that material, put a membrane, and then my holding sutures on the membrane to stabilize it, which is mandatory, and then close the site. After closing the site, I gave the patient a bridge on the adjacent laterals. Few years down the line, few months down the line, around 6 months later, when I started attaching the provisional to the implant, I realized that I have got a mucosal recession. Upper right central incisor is longer than the upper left central incisor, and the patient's smile is gummy. So I'm going to be in trouble here if I don't correct this discrepancy. So we decided that we will do an adjunct procedure known as the connective tissue graft here, and I shortened these provisionals. I asked my colleague Dr. Neil to do a connective tissue graft for me in as ideal circumstances as we could over here, And along with the connective tissue graft, he also released the flap and coronally positioned the entire gingival flap. And at the end of that healing, after around 4 to 6 weeks, we are now at an equal gingival level with the central incisors, almost equal. And when I see the final result, the discrepancy that was there, that was so big, uh, could not be corrected 100%, but this was something which we found acceptable in the end. Now, the summary here for this case is that because I did not have the tooth structure present over there to maintain the buccal bone, the moment the buccal bone is lost, in spite of the GBR, in spite of the uh, early placement protocol and not rushing with the immediate placement, in spite of good provisionals, in spite of customized abutments, and in spite of connective tissue graft, this is the best we could do. So when the number of implants missing are more, you need some of these adjunct procedures, and sometimes you need them multiple times so that you can achieve the end result. So that's our challenge in the aesthetic zone. But still, because we stuck to the 5 P's, we were able to achieve something which was clinically acceptable, and then we could see the patient finally smile and be happy at the end of the day. Okay, so the last case is a case in which I not only have to do now implant placements, I also need to look at a smile design aspect. So these are many a times implants in the aesthetic zone require us to uh, build up the entire smile along with the teeth which are missing. So I'm going to try and focus on that aspect here. There are three or four faulty restorations of the incisors. That's my starting point. I remove the restoration and I decide that both lateral incisors cannot be saved, but the upper left central can be saved. So I'm going to save that, and my upper right central incisor is missing. So at this point, I open the flap, do a partial extraction, place the implant in the delayed site in 1-1 region, and because of the concavity in the uh, bone, in the buccal bone now, I'm going to do some contour augmentation for that area and then use a membrane and suture the flap. Okay. Once this aspect has been done, I will need to give the patient a provisional. So I decided I'll load one implant along with the central incisor and make a 4 unit provisional, which I somehow tried to make it very acceptable and strong for the patient at this point. It's far from ideal, but we'll work on that as we proceed. At around 3 months, I did the second stage for my two implants which were submerged, and I went ahead with attaching the provisional abutments onto these implants to make a good provisional for me. If you see the incisor view now, you see none of these sites can compare to what bone contour the central incisor brings in. But still, the laterals have maintained whatever contour they had because of their shields that are present. And the upper right central incisor cannot compare to the bone contour of the natural tooth at all. No amount of GBR, no amount of connective tissue graft will give me a result which will be stable in the long term from a contour point of view. But still, this is healthy, so I'm not very concerned about this from a long-term standpoint. Okay, so now I go ahead and take my open tray techniques impression for these areas, get a stone cast board, and ask the lab to make me customized abutments on these hybrid bases, tie bases, so that I can have a cement retained restoration on these implants. So what I do is I do this in two stages. I first go the apartments, torque them in, pack the screw, and then I prepare the canines for the veneers and the premolars for the veneers. And after I have done the preparation of the canines and premolars, I then go ahead with the impressions for my final restorations. Okay. Now you see there's a metallic post over here, and because of the presence of that metallic post, I'll have to use Emax, which is high opacity or medium opacity. Otherwise, if I use a very translucent material, the gray of the metal will show through, and that central incisor will never match the remaining teeth. So I pondered on the thought that I should try and remove this metallic post initially in my treatment planning, but I didn't want to end up fracturing the root vertically in my attempt to do that. So I decided we'll live with this and we'll prosthetically manage the masking of that area. Okay, so that's my digital impression. And then I go ahead with my final restorations, which are then sequentially luted and bonded onto all these teeth. And look at how we started and see how beautifully we have finished up, not only with the placement of the implants, which you'll see later, but also from the point of view of the overall integrity of the smile in the patient's face. And that's what implants in the aesthetic zone is all about. It's we as dentists who have decided that we should have different subjects. Aesthetic dentistry different, implant dentistry different, full mouth rehab different. But there are many cases in which all these three disciplines come together, and only a thorough understanding in them will allow you to get this type of a end result. So that's my retracted view. That's an immediate post-op. And after around 6 months, you can see the tissues are now molded nicely to the underlying implants and teeth and abutments, and everything is looking good. If you see between the upper right, central, and lateral, there is no interdental papilla, but I never had that to start with. You see, when you are starting with these cases with no papilla to begin with, no amount of surgery can get that papilla back. The only way you can manage that area is by having a long connector and see that there is no dark triangle left, and showing that as a preview in your provisional to your patient so that they don't have a shocking end result where they complain about the lack of a sharp interdental papilla in between. For me, luckily, because this is not in the midline, the patients really did not complain about it. But this is the area in which you are going to be tested in the aesthetic zone. The interdental papilla, when you have nothing to start with, are difficult to manage. Yeah. So that's the close-up view. And these are some of my x-rays to show you the depth of the implant placement, mesodistal positions, connections, prosthetic fit, tie bases on which zirconia has been put, and then crowns and bridges on the adjacent teeth, all showing a good marginal integrity. So to summarize, this is my last slide. The 5 P's: planning. Take a proper CT scan, evaluate the 8 parameters. The more the number of red flags in the case, the slower your approach should be. The more you need to talk to the patient about the risk factors, and the more you need to work with mock-ups to tell the patient what your final result can be in the implant zone. The second, which is something which is non-negotiable, is your implant placement. It should always be in the correct three-dimensional position. And today you have the option of using stents, which are very economical. 2,000-3,000 rupees, you can make a stent for multiple implants, and then get your implants in more or less the right place. So explore that option. Okay. The third is using of PET, GBR, or a CT graft. One of these three things is always required, always, 100% of the time in the aesthetic zone. If you don't do any of these three, then you will have a suboptimal aesthetic end result. Provisional restorations is something you can spend a lot of time on in your prosthetic face to design it well, and then scan the provisionals and provide that information to the lab to let him design the restoration well and copy that shape in the final design. And prosthetically, as I already mentioned, I'm very strong and I firmly believe that abutments should be customized not only in the anterior zone but even in the posterior zone, but that's for another day. Customization is now not as expensive. You can customize even in titanium if you want, but customization allows your margin placements to be such that you can then negate the problems with any cement retained restoration by having more shallow margin placements. So, my last words of wisdom: an incorrect protocol will not get you the desired outcome, however hard you try. So, try in the right direction rather than trying hard in the wrong place and achieve a good result for your cases. So, once again, thank you to Dr. Aarti for giving me this opportunity to share this information with you. I will now ask her to look at the questions, ask me the questions, or you can ask directly whatever it is, and we can spend some time getting this subject a little more sorted. Okay, so uh, I'm going to stop sharing,
Yeah.
right? So
Right.
we only remain on Zoom, and I'm able to see all of you, and we can then go ahead with your questions.
Right.
I see that there are 22 questions over here. Let me scroll through if there are any questions. Okay. Uh, Thank you everyone for the kind feedback. It always feels good to see known faces and known people who appreciate what we are doing. So thank you very much. Okay, so the first question is from Dr. Poonam, and she's asking what are the bio-HPP crown cementation protocols? So the cementation protocols, if you make a Emax crown, are the same as that for Emax. So your Emax is etched and silinated, and then you use a resin cement. But you need to buy a bond known as Visual Link, which is available from Bradent, which sells the bio-HPP material, and that bond has to be applied in a very thin layer on the bioHPP and then light cured for 90 seconds, 90 seconds on all sides so that the bond is completely cured, and then you use your resin cement like Variolink to stick the Emax to the bioHPP. If you're using a zirconia crown, still you need the Visualink uh, bond on the bioHPP. But on the zirconia, then you can use what is known as the MKZ primer from Bradent, which allows the zirconia to be micromechanically bonded to the underlying bioHPP. So I hope that answers your question. And the next question is Dr. Kumar, who has asked me which GBR membrane and bone graft is used in the anterior region. So again, I answered that. When you're trying to regenerate the labial cortical plate, use autogenous bone first and then a xenograft. Okay. Or if you're doing only contour augmentation, then you can use directly a xenograft onto the buccal contour to allow you to get the shape that you want in the final restoration. The greater the amount of bone plate that you want to generate, the more the percentage of autogenous bone that you need to harvest. So I need say about 30 to 40% of autogenous bone, and the remaining 60% bone can be a xenograft of some form. Okay. Um So the next question is Dr. Vishwajit, and Dr. Aarti, please let me know when the time is up and I have to stop. Okay. So I have a few queries. Socket shield technique, flapless open flap. So generally we do it flapless. In 90% of the socket shield technique cases, we don't do razor flap. Whenever we razor flap, we tear the tissue away, periosteum away from the bone, and that will lead to loss of the buccal cortical plate by itself. But sometimes, in multiple socket shield cases, from canine to canine, if I feel that my visibility is getting impeded and I'm not able to see the shield and the implant placement correctly, I prefer to open the flap, check everything properly, and then close. Of course, the flap opening is not as wide as it would be for a GBR. It's a micro flap opening around 2 millimeters, and that does the trick for us. Okay. Next question is minimum length of the shield. Uh, Minimum length should be at least around 8 to 10 millimeters or two-thirds of the length of the root. Whatever is more should be achieved. It's like deciding how is the minimum length of a post and core when you're doing a post. Yeah, it's two-thirds of the length of the root or 10 millimeters, whatever is more. Okay. How much gingival margin shift should we expect after altering the contour of the provisional? You can go easily 1 millimeter apically or 1.5 millimeter apically, and at least zero point 0.5 to 0.75 coronally. It's easier to push the gingiva apically rather than get it more coronally. So whenever possible in my adjunct procedures, I try to build more tissues, so I have more tissues to work with, which I can then shift apically more easily. Apically shifting can be done even by laser contouring if I want later on. Okay, so how to remove graft chips from the ramus? You can have a automatic handpiece driven harvester. Take a incision along the external oblique ridge. How you do it for a wisdom tooth extraction? Open the site and sink this trephine or the ASC inside, and the particles will come out in form of a chip, which you can usually utilize uh, for your case. Okay. How much time does it take for the donor site to heal? Dr. Darshika has asked me this. Donor site to heal for a CT graft. It takes around, I would say, 48 to 72 hours for the blood clot to start reorganizing, around 2 weeks for the epithelium to start maturing, and at around 4 weeks' time, when you look at the site, it will appear as if nothing was done over there. With these CT grafts, because you are raising a flap, removing the graft, and suturing back, you will have a primary intention healing. So it's not as bad as a free gingival graft. The healing is pretty uneventful. Okay. In case of GBR for membrane stabilization, is membrane tacked better or a suture better? I prefer suture, although I have tacks. Sometimes I feel that when I'm tacking the membrane tears or the tack breaks. And the more cortical the bone, the more chances of tack breakage. So you can use tacks which are screwed on, but they are too expensive to justify their use in routine implant dentistry for me. Although I have them, I prefer suture. It's just good to master the suturing technique over the long term. In which cases do you give implants supported prosthesis versus Maryland bridge as a temporary? So if I have got good stability in the implant, I will make a provision on the implant. If I have poor stability in the range of 20 to 25 Newton centimeters, then I prefer to submerge the implant and let the Maryland bridge take care of the patient's aesthetic needs in the initial period. Okay. Can tissue augmentation be done after prosthesis is delivered? Of course, you can, but I'm sure your patient will not pay you for that because you have not planned it. And sometimes, in trying to do those things, if something goes wrong and you have recession, you will have a much worse end result. So, whatever you want to do, do it by the time your provisionals are done, and then try not to do any surgical work after a definitive restoration comes into the picture. Okay. When should we consider to fill the jumping distance, that is the distance between the implant and the shield? In case of a delayed or a full extraction where there's label plate and implant, I would today graft 100% of the times in the aesthetic zone. But when I'm using a socket shield, when I have my shield, then I don't need to fill that gap with a bone substitute, provided I make an immediate provisional. So if I don't make an implant supported provisional on the day of implant surgery, then I cannot leave that gap in the socket shield area empty. Then however small the gap is, it should be grafted if you're not making an immediate provision or at least a custom abutment. Okay, custom healing abutment. What is a long form of PET is partial extraction therapy. How long do we wait for a periapical cyst to place an implant? If it's a small cyst, you can place it immediately as long as you have enough parietal bone. If it's a big cyst, better to enucleate, graft that site, and come back at around 5 to 6 months and then place the implant. The next question is by Dr. Neha. If you do a soft tissue augmentation during stage 2 procedure, how much time do you wait for impressions? Ideally, you should wait 4 to 6 weeks. If you want a good result with mature tissue and your patient is not in a hurry, wait for enough time. It will go a long way in allowing you to get a robust tissue around your implant. Okay. So that completes all the questions that I was asked, and thank you everyone so much for taking time out in the middle of the day and attending this session. I really enjoyed it, and I hope you all had a great session too. Dr. Aarti,
Yes, sir. Thank you so much for such insightful lecture and
thank you.
actually many clinical takeaways for each one of us.
Thank you.
Does anyone have any further question? You can unmute yourself. Everyone is appreciating, sir, on the
Okay.
chat.
Yeah. So thank you everyone, and I will see you all around soon. Wish you all safe practices in these COVID times, and I pray that we all get back to normal days soon. Thank you.
So can we have a group picture?
Sure.
Yeah, if everyone
How
can
do we do that?
switch on the videos, all of you.
Okay. I'll keep smiling so that
Thank you. Thank you, all of you.
Thank you, sir. Thank you, Aarti.
thank you
Thank you.
everyone.
Thank you
Thank you
so
so
much.
much, sir.
Thank you,
Thank you
sir.
so much.
Bye.
It's
Pleasure.
always pleasure to hear you, sir.
Thank you.
Thank you so much, sir.
Thank you very much.
Thank you, sir.
Thank you. Thank you.